Welcome to today's panel, Can Academic Health Systems Be Learning Health Systems? This is part of the Hopkins Business of Health Initiative's monthly webinar series, Conversations on the Business of Health. I'm Dan Polsky, Director of the Hopkins Business of Health Initiative. HBHI is a Hopkins-wide initiative bringing together scholars from across the university, share a mission to advance health through affordable and accessible high-value health system. Our focus in our initiative is on the role of business and incentives in advancing health. So with that as a welcome, I'll turn the proceedings over to our moderator and the HBHI expert on today's topic, Jody Siegel, who's a professor at Johns Hopkins University in the School of Medicine. Take it away, Jody.
Thank you very much. Welcome everyone to the March webinar. I want to thank Dr. Daniel Polsky, as well as Liana Watson, who's the coordinator for our events. I'm Jody Siegel, professor here at Johns Hopkins University. I practice internal medicine. I'm a health services researcher and pharmacoepidemiologist. I co-lead our ARC-funded center to promote embedded research in a learning health system. Today's topic has the somewhat provocative title, Can Academic Health Systems Be Learning Health Systems? So let's enter into this discussion with open minds and let our panelists help us to reach our own conclusions as we think about our own health systems. While academic health systems and academic medical centers may have the resources and expertise to be effective learning health systems, there may be misaligned incentives that lessen the impact of clinicians, researchers, and operations teams working in these settings. I like to think that by aligning goals across research, teaching, and clinical operations, AMCs could more effectively integrate research into practice and influence their health systems. This webinar includes expert discussion about how academic health systems may better realize their potential. I'm going to start with just a few definitions for this discussion. Academic medical centers are hospitals that provide patient care and educate healthcare providers in partnership with at least one medical school accredited by the LCME or the American Osteopathic Association. There are approximately 6,000 hospitals in the US, more than 1,000 teaching hospitals, and about 200 AMCs. Many of these AMCs are part of health systems, which include many hospitals, most of which are not AMCs, although they may be teaching hospitals. I will introduce today's panelists, and you can read more about them on the HBHI website. So pleased to welcome Dr. Lucy Savitz, a professor of health policy and management at the University of Pittsburgh School of Public Health, where she also serves as the director of external affairs for the department. Dr. Savitz previously was vice president for health research in the Kaiser Permanente Northwest system and director for the Center for Health Research there. Before that, she was Assistant Vice President for Delivery System Science in the Intermountain Healthcare Institute for Healthcare Delivery Research. Dr. Scott Halpern is the John M. Eisenberg Professor of Medicine, Epidemiology, and Medical Ethics and Health Policy at University of Pennsylvania. He practices as a critical care doctor. He's the founding director of the Palliative and Advanced Illness Research Center at Penn, and he directs Penn Portal, one of the 16 U.S. Centers of Excellence in Learning Health System Science. Earlier in his career, he developed the construct of hospital capacity strain. And Dr. Chris DeRienzo is the Senior Vice President and Chief Physician Executive of the American Hospital Association. In this role, he develops strategies and resources that improve health outcomes in support of the mission of the nation's hospital and health systems. Most recently, he was the CMO of WakeMed Health and Hospitals in Raleigh and was previously Chief Quality Officer for Mission Health in Asheville, North Carolina. So delighted you accepted our invitation to join us this morning, everyone. So I'm going to turn to Dr. Savitz to begin, and Dr. Savitz will help us to understand more about learning health systems and how they function and how they might function.
Thank you very much, Judy. It's a pleasure to be with you all today. And I believe we're entertaining in the chat or in the Q&A questions from people as they arise.
Thank you.
So please don't hesitate to add your questions. We will have time for lengthy discussion at the end. And in the 10 minutes that I have today, I'm really asked to address three things. What is a learning health system? What's the historical context and evolution of learning health systems? And then a little bit about the maturity model, which is some work I've been involved with for a number of years now. So let me start with, what is a learning health system? I'm sure you've seen the definitions, probably most notably the Institute of Medicine definition that was published in 2012. And I think one of the things that points to the introductory comments that Jody was making is it really talks about in that definition the importance of aligning incentives and creating the culture for learning. And so I think when we think about the different settings where we're trying to sort of infuse or grow or mature learning health systems in an organization, that's really a predominant sort of focus as we think about it. But basically what we're trying to do is to really take knowledge that's generated from the data that we collect it as an artifact of the care that we're delivering in healthcare, and then actively engaging patients and families across the entire process. So we're not just sort of doing a focus group during a study and we're saying, okay, now we have a patient perspective in our work, but thinking about even from the design of the study, articulating the questions that are going to be answered, and all the way through the dissemination cycle of research. They're really important activating roles for these patients and families to participate in that work. And then lastly, and I think most importantly, just because we learn something, we have new knowledge and we have identified best practices, how do we embed them in the care delivery process? And so that leads to that virtuous cycle that I'm sure you've all seen that was first notably published in the Crossing the Quality Chasm report, where, and that was really sort of in many ways a closed loop, if you will. In our Mind the Gap paper that was later published, Jean Marie Gies is a lead author on that. Chuck Friedman is on it. I'm a co-author on the paper. And in that paper, we sort of open up the sort of virtuous cycle to include contributions to the peer-reviewed literature and actually taking learning from the peer-reviewed literature, which we can share across health systems, and infusing that back into this virtuous cycle where we go from performance to data, data to knowledge, and then knowledge to performance. So the one thing I will say, and I've been quoted as saying this, you've all heard the sort of quip, if you've seen one EHR, you've seen one EHR, they all get customized. I say the same thing about learning health systems. You've seen one, you've seen one. They're all very, very different, and they start in very different kinds of ways. Some start from a grassroots effort in a small scale and then sort of build up and infuse across the system over time. And others are a top-down decision that's made and resourced by leadership in an organization. There's no one right way to do it. Lots of people have come to this for very different conclusions and for very different reasons and rationales. So I hope that sort of gives you a flavor to it. And I think our sort of tendency to try and create a box to just define things and set a framework around them sometimes eludes the fact that there is this sort of amorphic kind of possibility that exists. And I say that because I've been around for a long time. This is my birthday month. I'm old. I've been around for many, many years working in this sort of realm. And to give you a little bit of historical context, Kaiser has 8 regions, and in each region there is a center for research. And each of those centers participates as independent learning health systems who share information across the system, certainly. The Kaiser Center for Health Research that I directed in Oregon actually was started in 1964. So when we think about, learning health systems, we didn't use those words. We've changed the semantics over time, but that was an initiative that was led and has persisted. It in many ways mimicked an academic department. It wasn't really sort of integrated into the system in the same way that we think about it in today's terms. And then if you cycle sort of forward in time, most notably in my career, in the mid-1990s, Steve Shortell created something called the Center for Organized Delivery Systems, and Howard Zuckerman created the Healthcare Systems Research Network. And those two groups came together, and it was a group of 9 healthcare delivery systems that set priorities, let out small RFPs to the research community, and then engaged them in research that would address the priorities of the health systems. And I think that's another key nugget of, what defines a health system. It's that the researchers are bringing the tools and rigors of research to the healthcare delivery space and addressing the priorities and problems that are faced by the healthcare delivery leaders. So it's the importance of making that connection, I think, is very vital to this work. So if you cycle forward in time, the Agency for Healthcare Research and Quality let out a call for projects in early 2000 on the Integrated Delivery System Research Network. It was a master task order IDIQ that was funded, and it created networks of healthcare delivery systems that wanted to come together and learn. I led one of those first initial ones. There were, I think, 13 other awardees at that time, and they were renewed in 5-year increments as Action 1, Action 2, Action 3, and Action 4. That master task order is no longer alive at ARC, but it was an important vehicle to show the value of this applied research and delivery system settings. And, as sort of time ensued, in probably about 2006, 2007, 2008, we saw a real need to train people to do this kind of work in delivery systems because our standardized protocols and curricula for PhD students or physician scientists was not really engaging people in a way that gave them the skills to operate within an operational setting and in applying their research credentials. And so we created at Academy Health something called the Delivery System Science Fellowship. This was a fellowship that was sponsored by Academy Health, but the salaries were paid for by the healthcare delivery system host organizations. And there were over 20 delivery system science fellows that were supported under that particular initiative. So what we saw as we're sort of evolving is that it was really a privately funded initiative where health systems were funding these kinds of efforts. The federal government started playing a role by providing research support to the delivery systems that were engaged in this kind of learning. And then we saw the advent of actual training programs to train people. Later, the Agency for Healthcare Research and Quality through the Corey Trust Fund funded the Learning Health System K-12 Awards. Those were 5-year awards that trained a number of physicians. I was actually a number of scholars, not all physicians. But I was actually a co-PI with Dr. Jean Marie Gies on that particular effort as it sort of came to fruition. And there were a number funded. And at the same time, sort of in sort of the same era, we got learning competencies that were developed by the Agency for Healthcare Research and Quality. There was a committee that was established. I was part of that committee that created the learning competencies for a learning health system scientist. And basically, it was 33 competencies that were aligned across 7 domains. And later, under the LHS K-12 awardees, the PIs came together and saw the need to add an 8th domain area around equity and additional competencies associated with that. So we have the sort of the national vision for the structure. And then we start to have the government support, which in many cases was additionally, sort of resourced by the delivery systems that were sponsoring these learning health system scholars that were coming in. As those LHS K-12 awards ended, we then saw the Corey through the trust fund help fund the Agency for Healthcare Research and Quality to fund the current training programs, which are the E-STAR programs under the P30 award mechanism. And so the training goes on, and the ideas that have sort of led up to this initiative have been really, really important to create the kind of workforce that we need as we move into the future, because healthcare delivery systems are strapped no matter where you look. There are shrinking margins. They're constantly being asked to do more with less. And many health systems are trying to move into value-based purchasing and new financial reimbursement models that really require this kind of expertise to come into the environments and help provide the evidence to support decision-making in healthcare delivery, which is really mission critical for survival and optimizing outcomes and access to healthcare delivery. But I think as I sort of look across that arc of training, of funding for this kind of work, I think one of the major shifts that I saw that was fundamental in terms of how we think about what is a learning health system is this sort of notion when we originally had a number of working groups and subsequent publications that came out of the Institute of Medicine on this topic, they always talked about the learning health care system. So we always thought about it up until that point within the confines of the walls of our clinics and hospitals. So it was really focused on health care delivery. And what we saw in the evolution of this, and largely through the COVID pandemic, which really opened our eyes to, thinking beyond the walls of our clinics and hospitals, we now commonly refer to it as learning health systems. And I think those semantics are really important because we now realize it's an ecosystem approach, particularly as we've integrated priorities around social risk factors and trying to address those social risk factors and optimizing care delivery and efficiency of care delivery. We've really had to think about who are the community-based organizations that we need to work with in our community. What are the other sort of players and levers and stakeholders that we need to engage in these processes? And so I'd say, as we've sort of evolved over time and we've gone from private funding to government funding to shared funding over the course of the evolution of training the workforce and conducting the research, that notion of the ecosystem of health in which we're operating is really important, especially as we go into value-based purchasing, which focuses on population health. And I made the comment as I was sort of introducing this that if you've seen one learning health system, you've seen one learning health system. And this has been a perplexing problem for a number of us because a lot of people come and say, how do I become a learning health system? Am I a learning health system? What can I do to sort of travel along that road, and what are the strategic priorities for doing that? And the learning health community was founded by Chuck Friedman, who's at the University of Michigan. He actually is a co-PI on one of the eSTAR programs, and Josh Rubin. And I was part of the group that they pulled together before the pandemic. And we started to bring together this group of national experts across, different organizations who are coming together to understand what is a maturity model and how do you move across a life cycle as a learning health system. And we went on hiatus during the pandemic for obvious reasons because we were all pulled into other directions. But following the pandemic, when we sort of were emerging from that, the learning health community wanted to partner with Academy Health. The Academy Health has a learning health system interest group if anybody's interested. All people are welcome to that. And I co-lead the Learning Health System Interest Group with Hal Loved, with Sarah Green, and Mike Gold, and others. But we brought together those groups and established a group of 53 experts across the field that continued to meet on a regular basis and went through several learning loops. And what I can tell you we've learned through the maturity model development process is that we've been able to come up with really 4 domains of activity. And so those 4 domains, and we call them pillars. The first pillar is leadership and governance. So what are the competencies for a mature learning health system that are necessary with respect to governance? The second pillar is socio-technical environment. And the socio-technical environment is crucial. We can't do anything without the data that we can turn into knowledge that I've talked about. And so there's that particular domain, which has associated competencies with it. And then the third is improvement execution. And so improvement execution is really important because it doesn't matter if you do the research and you come up with great findings, if you can't implement it into practice, you haven't really fulfilled that virtuous cycle that we've been talking about. And the sort of fourth pillar is one that cuts across all of them, and that's culture and values. And so what our group, our leadership of the group that's sort of pushing this maturity model forward is Chuck Friedman and Josh Rubin, who come from the learning health community, together with myself and Elizabeth Cope, who come from the Academy Health side. And what we're trying to do now is we're working with health systems across the country to validate the model. And so there are 10 organizations that are actively working with us. Your organization may be one of them. I know Johns Hopkins is. We're really grateful for that. And we'll be having a session at the upcoming Academy Health annual research meeting to present the results of that first validation process. And I know that's been a lot that I've sort of put forward and put on the table. I'm really looking forward to the discussion and the Q&A, and hopefully you'll remember to sort of use the Q&A process to chat in your questions so that we can take them later. But with that, I'll turn it over to my colleague on the panel.
All right, thank you very much. And there are some questions already, one including about IT and EHR. So we'll
happy to answer
that. Okay. All right, thank you. Next up, Dr. Halpern, who's going to talk more about experiences of doing research in a learning health system and what he has learned.
Thanks, Jody, and thank you all for participating today. I'm going to lead off with just two introductory comments, framing comments, give you a little idea of sort of the perspective I bring to these issues, and then I'm going to try and focus on sort of 5 specific areas of learning health system science that are largely overlapping with the 4 pillars that Lucy articulated. But what I'll do is highlight some experiences working in academic health systems and non-academic health systems and how they sort of tend to fall out in these domains. So first is Jody led off with a definition of an academic medical center that was rather hospital focused, and I'd like to highlight that to the extent that it's certainly possible that an academic medical center is either a standalone hospital or a series of hospitals, but if it is, it's going to be intrinsically limited. A learning health system, the degree to which a learning health system is an integrated system, meaning inclusive of outpatient, community, and home-based care, as well as inpatient facilities, that will directly correlate with the degree of learning that's possible. It's simply not possible to learn as much if you're focused on a single unit or facility, particularly an inpatient one, if you can't also measure what happened or what brought these patients into the hospital from the community, from the outpatient setting, and if you can't follow them up after they leave the hospital and go back into the outpatient setting. So good learning health systems will have all of those components, whether they are academic or not. Second is, Lucy kind of stole my thunder with the, if you've seen one, you've seen one framing. That was going to be like the subtitle of my comments. But I'll just build on that and say that there is tremendous heterogeneity within academically oriented learning health systems, as well as in non-academically oriented learning health systems. And if you try, I would actually reframe this session entirely, not as can academic medical centers be learning health systems, but rather what are the relative pros and cons of academic versus non-academic medical centers in the service of learning health system science. Okay, so with those introductory remarks, the perspective I bring is largely as a learning health system scientist, and particularly one domain of learning health system science, which is the conduct of pragmatic randomized trials that are embedded within learning health systems. I've been PI or co-PI of about 30 such trials to date. I would say about 40% of those have been conducted entirely within academic medical centers. About 40% have been conducted entirely within non-academic medical centers. And about 20% have been conducted in a hybrid where some of the centers are academic and others are not. And what I've learned is that there is absolutely no reason fundamentally to think that academic medical centers can't be every bit as good at learning health system science as non-academic centers. And in fact, there are some things to suggest that they could be much better. So now I'm going to dive into sort of what my experience has taught me across 5 domains. So domain number 1 is data quality, data reproducibility, and perhaps most important of all, data accessibility. So it goes without saying, and Lucy articulated this nicely, that to the extent that we can access and organize data efficiently, we are going to learn in direct proportion to that organization and access. That involves having common data models that underlie the back end of how data is captured and stored in medical centers, whether they're academic or not. It requires data wranglers who are skilled and who have authority or permission to cull those data and manipulate them into analyzable data sets. And it requires an overall governance structure that ensures that appropriate privacy considerations are respected and promoted, without unnecessarily limiting access to data that would enhance learning. And I would say that there's nothing in my experience that is fundamentally distinguishing between academic and non-academic medical centers in this particular domain. I've worked with a lot of academic systems that are incredibly strict in this regard. I've worked with some that are well along their journey toward making data a more accessible commodity. And the exact same thing goes with non-academic centers. We have in one project we're doing right now that includes several non-academic health systems. We have a saying on our team that one of these health systems is just unfun island. You're just not allowed to have any fun working with this system because their rules on accessing data are so strict that it's just like I would go into each of these conversations with a full head of hair and I leave with the haircut I now have. Like it's just impossible. And I'm sure there are academic systems that are just as restraining, but that's an example of a non-academic one. And that's really key. Number 2, resources and skills in manipulating the electronic health record and the governance of electronic health record manipulations. So I don't think it's a stretch to say that the advent of the electronic health record has been the single greatest catalyst of the quality and depth and breadth of learning health system science that can be done over the last 30 years. It just exponentially increases the range of learnings that we could conceive of undertaking. Particularly for me, where a lot of my work is focused on building or reimagining the electronic health record so that we can use principles of behavioral economics to nudge clinicians to behave differently without constraining their decision-making autonomy. All of that work is built in the EHR. And if a health system is very mature in its governance structure and very skilled in its EHR builders who can not only readily and creatively manipulate the electronic health record, including requests for data entry among various clinical staff, the presentation of our practice advisories to clinical staff, et cetera. It could also include manipulations to the patient-facing portals that are within electronic health records. All of these things, the greater maturity of resources to do those manipulations, the greater the learnings that are going to come. And again, in this space, I've worked with some non-academic centers that are really, really good at this, some academic centers that are really, really bad at this, and vice versa on both sides. Third would be there needs to be not only content area expertise or clinical area expertise, but also, and perhaps even more importantly, stakeholder influence, by which I mean, if you want to do a learning health system project in the space of reducing unsafe opioid prescribing, for example, it is really helpful if that health system has an opioid use task force. And it's even more helpful if that health system's opioid use task force has buy-in from its various stakeholders, which includes palliative care clinicians, it includes orthopedic surgeons, it includes all the different types of clinicians who prescribe all sorts of opiates. And to the extent that there is community and buy-in and collective decision-making around how that system's going to approach the important topic of restraining without unnecessarily restraining opioid prescriptions, the better the science and the learning is going to be. And again, I haven't really witnessed anything that's defining uniquely in academic versus non-academic settings along these lines. Some systems do it really well, some systems do it really poorly, but it doesn't, break out differentially across academic lines. Fourth, has to do with cultures that involve the privacy offices, the institutional review boards, and the compliance offices. And again, this has to, I'm thinking about the health system that we refer to as Unfun Island here, because the same thing comes up. There are some privacy officers that overinterpret and anticipate like the next regulatory requirement that's going to come on down the pike. And it's almost a model of anticipatory obedience without really needing to obey anything that doesn't actually exist yet. Others are on the opposite end of the spectrum. They're going to take the vantage point of, we want to allow the maximal access and use of patient data that is within the letter of the law as it exists today. And again, where you lie on that spectrum is going to influence the degree of learning that can happen. Correspondingly, take institutional review boards. Boy, if there's ever an entity for which if you've seen one thing applies, it's to IRBs. How IRBs think about reimbursement of research participants, how IRBs think about waivers of informed consent, how IRBs actually understand and implement the common rule is incredibly variable. And I will say that in general, my experience has been that IRBs that are within academic centers, particularly high-profile research centers, certainly this is the case in my institution at Penn, the IRBs in particular at Penn tend to be a lot more progressive, forward-thinking, and knowledgeable about what the common rule says, and importantly, what it actually does not say, than IRBs in non-academic systems. It's very important to emphasize that that is not a perfectly generalizable statement. And it's really a reflection of, in my experience of working with maybe 40 different health systems, on average, the academic IRBs have been a bit more progressive minded than the non-academic ones. But it's possible you find another 40 health systems where the trend would go in the other direction. And then lastly, and this is the one area where I think that, in theory at least, academic medical centers ought to be better set up for learning health system science than non-academic ones. And that has to do with the potential for collaboration between scientific experts, by which I'm talking about statisticians, experts in randomized trial design, experts in the collection of patient-reported outcomes, experts in implementation science, experts in human factors design, all of these things that are so fundamentally important to good quality learning health system science. In general, sort of by the nature of what they do, academic health systems ought to have greater expertise in those scientific disciplines in-house. In theory, if those researchers worked in close collaboration with operations leaders, then that would position academic health systems to be very successful in learning health system science. That's in theory, but what we've all observed in practice is that in a lot of academic health systems, the researchers are in a silo over here, and the operations leaders are in a silo over here, and the communication between those silos is rare and of low quality when it does occur. And it's that siloed nature that I think raises a lot of the gestalt that academic health systems aren't well set up for learning health system science, but that ought to be a solvable problem. I'll stop there. Thank you.
Thank you very much. I will use my prerogative. Tell us just in a couple minutes, after your trials end, what happens next? Are your findings integrated into the delivery?
Well, that depends on a number of things that I think also don't have much to do with whether or not a system is academically oriented. The things that it depends on are, A, most importantly, what did we find? Did the interventions that we designed produce results that were at very least beneficial to patients, and preferentially beneficial both to patients and the health systems themselves?
Mm-hmm.
That's criterion number one. Close behind that is, how quickly did we generate the results? Because all too often, you do a trial and then it takes longer than expected to actually acquire all the outcomes data related to sort of the first issue I mentioned about data access and quality. And then you do the analyses, and then you realize that some of the data were not actually organized in the ways that they were supposed to be. And then you have to redo the data polls, and all of these things lead to delays. And the longer the delay between the end of the trial and the production of knowledge, the less likely it is that those interventions are going to be implemented regardless of what the results were. So those are some of the considerations.
Yeah. Good. Thank you. All right. I'm turning to Dr. DeRienzo. Tell us a little bit about variation in AMCs and what you see from your vantage point at AHA.
Yeah, thank you, Jody. I know we are running a little bit long, and so I will try to keep my comments relatively brief so we can get to some of the questions. So I've been at AHA now for 2 years, and in 2 years, I've been to 35 states and managed to rack up 650,000 frequent flyer miles, which makes me exceptionally popular with my extended family. I've done that travel, though, because there is a wide spectrum of what hospitals look like in America. And my entire career, both in executive leadership and in practice, has been in North Carolina. And I have worked in every conceivable kind of health system that one can either work in or lead in North Carolina. But I did not understand Texas. I did not understand Oklahoma or Western New York or Oregon when I joined the AHA. So I spend about 150 days on the road a year getting to see what that spectrum looks like. And if I were to now quadruple click on the if you've seen one, you've seen one, that is as true for community hospitals as it is for academic health systems. And I think that matters. I think about Hopkins, for example. Johns Hopkins Health has a presence in multiple states. So not only do you have your sort of core big academic hospital, I was up there last month visiting with Dr. Miller, and I got to see all of the wonder that is JHH, but you've got a children's presence in Florida, not to mention community presence throughout your area within Maryland. I think about Oklahoma and KU in Kansas, and they have large, what traditionally would be thought of as perhaps a closed medical staff academic teaching hospital in certain parts of the market they serve. But in other parts of their system, there are small open medical staff, community hospitals that are still part of that academic system. I think about Cleveland Clinic that has multinational presence. And how does one begin to conceive of drawing learning in from sites that operate under completely different practice environments? All that really matters because I'm not an academician, and there are two much more highly qualified individuals to answer some of the questions in the chat than me. But as an operator, if I were to boil down the notion of being a learning health system into its most basic construct, to me, it is about how do I drive continuous improvement? And I had a mentor early in my career who said, Chris, it's sort of like fishing. First of all, people need to know that their job is to fish. Because if they don't know that's part of their job, they're not going to do it. And so at one health system I worked at, our chief operating officer would go to orientation every 2 weeks and say, look, folks, we hired you to do two things. First, to do whatever it is we hired you to do, be that a cardiologist or an EVS technician or as a revenue cycle employee or whatever. The second part of your job is to figure out how we can help you do it better. And that was part of literally every orientation. And that meant that every member of the team knew that part of my job is to participate in continuous improvement. So that's step one. Step two is you have to buy a fishing pole because people can't fish without tools. So you have to make some investment in the infrastructure required to support that continuous improvement. Third, you have to teach people to use it. I am not good at fishing. I didn't grow up fishing, so if you just hand me a fishing pole, I'm going to fail. So we have to invest in teaching people how to use the tools in the way that they're intended. And then lastly, and frankly, I think this is most important, we have to recognize you when you catch fish, because it's hard. Even if I have told you it's what you're supposed to do, I've built the time into your day to do it, I have given you a fishing pole, and I've taught you how to use the fishing pole, you still have to go catch the fish. So we have to have a way to recognize that as success. And I think one unique challenge in the universe of academic systems is you serve really three crucial missions. There's obviously the core clinical mission of effectively all hospitals in America to serve our communities. But then you are also striving to advance the art and science of medicine. And that is its own crucial mission. And then thirdly, you are training and growing the next generation of clinicians and scientists and all of the other members of the health profession. And so as a result, that means that we have to get all sorts of different people with all sorts of different infrastructures grounded on this one concept in the clinical delivery system that is continuous improvement. So I think there's an extra challenge there. How do you implement that as an operator in the universe of community health systems? Here's how I've seen it done best. When you try to build bespoke measurement systems, unless you have an inordinate amount of resource, that's very difficult to scale. So the way I've seen this kind of learning done best is effectively a modular approach where within some specialty, and I'm a neonatologist, so say neonatology, you can get the neonatologists together to agree on what is the evidence-based pathway for XYZ. And I don't discount that because getting neonatologists to agree is not always easy. And I'll use pre-intubation medication as an example. There really is no perfect way to do this. So we all got to agree to at least do it the same way. And then, to Scott's point, we need partners who can build that into the EMR. So it's easy to do and perhaps a little bit hard not to do. And then once it's built in the EMR, we have to measure. We have to measure what happens when we and my partners are following the pathway from a patient outcomes perspective, from a clinical, from an operations perspective, and then what happens when we don't follow the pathway. But then the last part is we have to learn from that. And depending on the nature of your infrastructure, academic, community, open, closed, employed, independent, how you learn from that and the opportunities are fairly widespread. So I'll use an example around opiates. In one health system I worked in, we built this kind of a dashboard for the amount of opiates used in certain surgical procedures. And it was actually that surgical subspecialty who was very interested in that. And so we could do that in this modular program that we had built. The surgical subspecialists were part of the development pathway, so there was trust in the data from the outset because it was their partners who were involved. And so they decided this is what we think right is. We built that, and then we started measuring it, but then we saw a difference. And it turned out that there was a delta between what was being prescribed for population A and population B, which meant we now had to have a mechanism for that group to begin to understand, because you don't want to immediately jump to, well, I think this has got to be the reason why. And when you've built the kind of infrastructure that we've talked about here to learn why that's happening, and you equip teams with the ability to do that, that's when learning happens. And now we can drive the flywheel the next step. I've seen that work in every conceivable kind of inpatient and ambulatory subspecialty. And there's frankly absolutely no reason that one hospital or one system is either more or less predisposed to be able to execute on that. It's just a really challenging thing to execute no matter where you are. I know we've got a lot of questions in the chat. And again, folks on the call who are true academic experts in this space. So I'm really looking forward to the Q&A.
Thank you very much. Good. All right. I think I'll jump around a little bit, but I think I'm going to start with the question about, but specifically about the role of life science companies or pharma. I think I'll broaden it a little bit to more about financing or paying for these activities. Mm-hmm. I think in Dr. Halpern's examples, many of the pragmatic trials are funded by NIH or other federal sources. In other health systems, I suspect that the health system invests in the learning. And what our guest has asked about is, what about life science companies or pharma participating and maybe even funding these sort of learning activities? Could any of the panelists speak to that?
I'll comment, and while my other colleagues prepare their comments and reactions to that. I think, as we look at this ecosystem approach to how do you accomplish this kind of work, it's becoming more and more complicated. And I think one of the things we're going to see is the advent of learning networks where multiple systems and other players come together to address some of these questions. With the advent of AI, large language models, and our ability to learn at different scales. So I know of a number of initiatives that have been co-funded by life science organizations and pharmaceutical companies. And, the real consideration as a researcher, we've always sort of wanted to be sort of at arm's length, and we don't want to sort of have some kind of constraint on our ability to publish our results. And so those kinds of relationships are critical to assure partnership.
Yeah. Other comments about funding these activities? Because I do think that's one of the challenges and where the incentives of academic researchers don't line up well. We can't do this in our spare time.
Well, I think that you know, a number of the learning health systems that I've been involved in personally have actually resourced the initiative within their own organizations. And I think that's, you know, sort of a conversation that has to happen with respect to, you know, how do you grow the learning health system within your organization? Is, you know, if you're answering operational problems with the tools and rigors of research, there is a sort of return on investment that's, you know, you can demonstrate.
Mhm.
I'll just add that, you know, I think we need to think broadly about potential parties that would be willing and interested to fund this sort of scholarship. You know, we probably can't rely just on NIH and PCORI. I think a lot about Epic and Cerner and the other big
Mhm.
electronic health record companies that should have aligned incentives with the goals of some of the learning health system science that we do. In the sense that if we figure out redesigns of the EHR that make care delivery better, and if the settings in which the work is conducted are sufficiently generalizable to be scalable across heterogeneous systems, then that should have an ROI for Epic or Cerner or whomever. And at least in theory, groups like that might be convinced to support some of this scholarship. I don't think we've done a good job making that case as yet, but it's possible.
Yeah, thank you. You know, one of our recent training sessions for our learning health system scholars was about making the business case to
Mhm.
leadership, right? How do you show them that what they're proposing is important? Good. Dr. DeRienzo, did you have anything on this topic?
I don't think I have much to add to what Lucy and Scott shared. Yeah, I think, and there's another comment within the Q&A that speaks to this as well. You know, as we think more broadly about the extension of healthcare into more of what we define as health, there are obviously going to be opportunities to think beyond learning outside not just the walls of health systems, but the rest of the healthcare community. I don't
Mhm.
exactly know how or what that looks like, but to Dr. Halpern and to Lucy's point, the Dr. Savitz's point, I think there are plenty of opportunities to think creatively moving forward.
Yeah, good. And a question just came in about the role of engaging patients and the public in this work. Is there a systematic way we should be doing this best?
You know, I think it really depends on the nature of the study, but I've been convinced that it's hard to find a study that couldn't be made better by stakeholder engagement writ large. And at the top of the list of those stakeholders often is patients. I think, you know, this is the perhaps the single greatest thing that PCORI has done is make that a requirement of their funding model. And it's gotten those of us who go after funding for a living to really rethink how we were doing business and conducting our scholarship. And now we do it as almost a reflex because that value add is so profound that it feels like we were swimming upstream with completely opaque goggles before.
Well said. That was very
Yeah.
well said.
Yeah, thank you. And I think in just the last couple minutes, because there's been a couple questions about EHRs and compatibility. I know one of the early triumphs of the old HMO Research Network was really their common data model. How valuable is that? I think it's valuable when you're looking across health systems. I don't know, Lucy, if you want to say something about that.
I can say a few things because I actually was the director for a year when I was at Kaiser. And the HMO Research Network has sort of morphed into the Healthcare System Research Network, and it's still a very active and vital network with 19 member delivery systems across the country. I've worked in two contexts. So I also worked for the High Value Healthcare Collaborative from 2008 to 2019, and that was 16 delivery systems across the United States that came together. And the data model we used there was, it was a data trust. So all of the systems contributed their data. So administrative data, EHR data, claims data into a central repository, and that data were aligned within the data trust. The sort of HCSRN model or Healthcare System Research Network model is a federated model. So everybody holds their own data. There's a common data model. I think, Scott made some really important comments when he was talking about, how do you sort of unleash the data and sort of liberate the data. And part of it is, and that's why in the maturity model, we talk about socio-technical pillar, because it's not just the data, it's the analysts who understand the data and can sort of bring that data forward in a way that's usable. And so I think, if you're an organization working in any particular area, even as an independent learning health system, the extent to which we create standards for the data, think about social determinants of health right now. Those data are collected in a lot of different ways, and it's really difficult to sort of benchmark or comment on what you've been able to do in a particular area based on how you've defined certain variables. And so I think the common data models sort of prepare you for that next leap of learning that I really think the advent is coming for more and more collaboration across health systems, not as independent learning health systems, but as learning health networks.
Yeah.
Jody, the only thing I might add to that is, I completely agree that to a point, the reliance on expert analysts is crucial. But I've also seen when the flywheel gets so powerful that there's such a pull to engage in that continuous improvement that you couldn't hire enough analysts to possibly meet demand. And that's where having a federated model where you've created enough of an analytic sandbox for bedside clinicians to be able to engage appropriately with certain aspects of data can be really powerful. And I've seen one version of that had something like 85 different care process models. And so the clinicians within a particular subspecialty could run their own analysis and understand relative to their partners, what are we doing? How are we doing it? There's sort of this second bridge that then needs to be crossed. And it really is a powerful pull once you generate that flywheel.
Yeah, and Chris, I agree with you completely. The other point I would make is that when you think about it, these organizations have limited bandwidth. And so the other key piece of this is who sets the priorities for how those continuous quality improvement resources are going to be used. And so that's why sort of the leadership and governance of the learning health system becomes really important to say, well, this is an interesting project, but it's not necessarily the highest priority today.
Yeah, good. Well, thank you. We've learned so much from Dr. Savitz's pillars to Dr. Halpern's 5 pieces of advice and Dr. DeRienzo's fishing analogy. So grateful to everyone. This is an exciting time, lots to do, and maybe this is something we can revisit again later. So thank you to our panelists, and thank you to Hopkins Business of Health Initiative for this opportunity. And very much thank you to our guests today.
Thank you. Good luck, everyone.